Bismillahirrahmanirrahim. Now we are talking about the classification of migraine. Classification. Migraine are classified into the following groups: migraine without aura, migraine without aura, migraine with aura, migraine with typical aura, migraine with typical aura or aura, or migraine with typical aura with no headache, not headache, with no headache. It is no headache are present. Migraine with brainstem aura. This is brain stem aura. It is migraine without aura. Migraine with aura. Migraine with typical aura. Migraine with typical aura with not headache, and brainstem aura. Number 6 is the familial hemiplegic migraine. That is familial hemiplegic migraine 1, familial hemiplegic migraine 2, familial hemiplegic migraine 1, familial hemiplegic migraine 2, and familial hemiplegic migraine 3. And chronic migraine. The chronic migraine is the migraine with episodes 8 or more than 8 in 1 month, or there sometimes may be headache on alternative days per month. Now we discuss the complication of migraine. Complication. The complication of migraine is status migrainous, status migrainous, persistent aura, and migraine aura triggered seizures. Migraine aura and triggers by seizures. And there is recurrent GIT disturbance. Recurrent GIT disturbances. And number 5 is benign paroxysmal vertigo is also the complication of migraine. There is one research that states the symptoms of migraine. We will discuss that research. In this research, 500 patient was collected of migraine. The nausea were the presenting sign and complaint in 87% of these patients. The photophobia was the complaint in 82% of these 500 migrainous patients. Light-headedness and and scalp tenderness. Light-headedness was the symptoms in 72% of these patients. Scalp tenderness was the symptoms in 65% of these 500 patients, and vomiting. The vomiting was the complaint in these 500 patients. This percentage is 56% of the patient. 56% of the patient in this research is complaints of vomiting, scalp tenderness. In these 500 patients, there is 65%, and the lightheadedness 72% of the 72% of these 500 patients say they have lightheadedness, and photophobia in 82% of the patients say that they have photophobia. And nausea is the 87% of the complaint of the patient in these 500 patients in research. Now we will discuss the treatment of migraine. Treatment. Note that the treatment of migraine is individualized. For each and everyone, there will be a separate treatment of migraine. The treatment of migraine first is the patient education. So we must educate the patient to reduce stress. Healthy diet. Eat healthy diet. Regular exercise. Yoga. Transcendental meditation. Transcendental meditation are the meditation and techniques and medicine that we normally use in migraine and other disorders. Transcendental meditation in Urdu we call Aham Dawaiya. Scalp massage and sleep pattern. So we must educate the patient about the sleep pattern and avoidance of alcohol. Because alcohol can trigger the migraine, and avoidance of coffee, cheese. So we must educate the patient about these habits. Now we will discuss the pharmacological treatment of the migraine. First, if the patient comes to the migraine with no previous history of migraine, we will give the NSAIDs. If there is severe pain, we will give the IV diclofenac potassium. To reduce the pain and give the normal education to the patient. If the patient says that they have used before the NSAIDs and is no renew of NSAIDs, now we will describe that is mild migraine. So after this, if NSAIDs fail, first we give NSAIDs. That is 500 mg of paracetamol. Also we use aspirin. For the start time. We give the aspirin, acetaminophen. We should give caffeine. If these fail, so we give the second line of treatment, that is NSAIDs plus triptan. Studies suggest that the NSAIDs in combination with triptan has efficacy more than 80% in treating the migraine. So we give the NSAIDs and triptan. The NSAID normally we give naproxen 500 mg, triptan 500. If this does not work, so we will give other treatment guideline we will discuss later. Now we will discuss the triptan. Triptan along with NSAIDs is most effective in the migraine type of headache. Triptan and NSAIDs. Now we will discuss the various type of triptan. First is sumatriptan. Sumatriptan is 5-HT1B1D agonist. 5-HT1B1D agonists. Sumatriptan we normally use 50 to 100 mg. 50 to 100 mg. 50 to 100 mg at the onset. After 2 hours, maybe repeat. After 2 hours, maybe repeat. But remember that the triptan are contraindicated in the patient with the cardiovascular diseases because it can cause tachycardia, irritation, and heart block sometimes. So we must be familiar about the cardiovascular disease of the patient before giving the triptan, especially at higher dose. Other is fuvatriptan. The fuvatriptan we normally use 2.5 mg at onset. Other is zolmitriptan. Zolmitriptan and fuvatriptan has the highest efficacy. Zolmitriptan we use 2.5 mg at onset. 2.5 mg at onset, and then after 2 hours we maybe repeat it. Repeat this triptan. If we have difficulty, for example, if the patient have difficulty in taking orally these medications, if patient have difficulty in taking orally, so we must give in the subcutaneous injection or intravascular injection of the ergotamine. Triptan has subcutaneous injection also, so we can use the subcutaneous injections. If the patient says that I don't like the injection, so we can use the nasal spray for triptan. So we can use the nasal spray. Nasal spray for migraine. The nasal spray for migraine is for sumatriptan. The brand name is Imitirex. This is the nasal spray for tryptophan. Sorry, somatryptophan or zolmitriptan. This is the nasal spray. The somatryptan normally in the nasal formulation is 5 mg. 5 mg and 4 spray we can give. 4 spray we can give. There may be repeat after 2 hours. May repeat after 2 hours. Other is zolmitriptan spray. Zolmitriptan nasal spray. It is 5 mg also. We give 1 spray only. 1 spray of zolmitriptan. May be repeated after 2 hours. May be repeated after 2 hours of initial spray. This zolmitriptan spray not exceed dose of 10 mg. Don't exceed. Then 10 mg. The dihydroergotamine nasal spray is also available. The dihydroergotamine nasal spray is also available. Dihydroergotamine nasal spray. It is also available in the market. Even the free needle device, any free needle device or needle free device is also available. Needle free device for migraine also available. I have told you that the migraine has individualized treatment. Each patient has needs separate treatment. So if there is menses related migraine, so we will treat this migraine by the ergotamine nasal spray. Ergotamine nasal spray or estrogen patch, and other is triptans. Now we will talk about the migraine with vomiting. If there is severe vomiting, we can give the dopamine agonists, that is metoclopramide. We can give also the dopamine agonists, that is metoclopramide and other drugs for other drugs. The metoclopramide we can give also, and other antiemetic we can give also. They can be used in the treatment of migraine. If the patient has severe vomiting, we can give the patient metoclopramide, chlorperazine, and chlorperazine, metoclopramide. These type of medication is dopamine agonists. The dopamine These type of medication is the glutamine agonists, and they help in the chemotrigger zone and prevent the vomiting. And this is also used in the treatment of the migraine. If there is headache recurrence, in the headache recurrence, if there is headache recurrence, we can give ergotamine 2 mg. Ergotamine 2 mg. This is most effective with the recurrent stage. First of all, we will give. Now we will discuss, summarize the treatment of migraine. In the migraine treatment. In the migraine treatment, first we will educate the patient about the lifestyle modification, exercise, diet, and avoidance of alcohol and caffeine. First is patient education. Patient education. Second, if it's mild migraine, more 1 attack per month, we give NSAIDs. And sometimes it's combination with caffeine. NSAIDs may be paracetamol, brufen, etc. Naproxen 500 mg. Aspirin. If the patient complain again of migraine, we will give the triptan. But triptan must not be given with the patient having cardiovascular diseases. It increases the heart rate, it can cause tachycardia. This will not be used in the patient with cardiovascular diseases. We give the triptan with the NSAIDs. It is 80%, more than 80% effective. If the headache recurrence occur, we give ergotamine 2 mg. It is most effective in the treatment of migraine. If the patient has female and menstrual related disorder, we give the triptan for female in menses. We give the triptan plus estrogen patch and ergotamine. If there is severe vomiting, we give ergotamine with metochlopramide. Metochlopramide is antiemetic, that will control the vomiting. If there is, the patient has other type of headaches, so we can give, if the pain is severe pain and we need immediate relief, for immediate relief of the patient, we give subcutaneous triptan, but this subcutaneous triptan is costly. They have much more cost. We can also give the diclofenac potassium injection. Diclofenac potassium. Why we cannot give the tramal? The formula is the opioid. Why we cannot give opioid? Some studies suggest that when we give opioids for more times, this can trigger or induce the recurrence of migraine attack. So we rarely, for example, for one time we can use tramal, but for many time once we can use एक time तो चलता है, but for many time we cannot use the tramal. Instead of tramal we use the NSAIDs. There is subcutaneous injection also available of the triptan for immediate relief, that is work to 10 to 15 minutes, work within 10 to 15 minutes. Ergotamine injection also available, ergotamine also available, but they can cause vomiting. So we combine this with the metoclopramide. They can cause directly vomiting. We can combine with the metoclopramide. If the patient does not like the injection, so we can give the patient to triptan nasal spray, or ergotamine nasal spray. Ergotamine nasal spray is effective. Usually we give for the menses related disorder that cause migraine. Triptan nasal spray are also available by the name of Imitirex, and other name available also. Now we will discuss the prevention of migraine. That how can we prevent the migraine, and which therapy is the good for migraine attack. For the prevention of migraine, there is many drugs that they depend on each patient. Prevention of migraine. If the patient is not obese, so we can give the valproate. But the side effect of valproate, that can cause weight gain and hair loss. We cannot give valproate in the pregnant woman because they can cause the hepatotoxicity. The valproate dose is 400 to 600 mg. Valproate dose is 400 to 600 mg for the prevention of migraine. If the patient is obese, so we can give topiramate. The topiramate dose is 25 to 100 mg per day. The side effect is weight loss and glaucoma, sometime also, but not all. If the patient is hypertensive and also have migraine, we can give beta blocker for the patient who is hypertensive and also have migraine. We can give the beta blocker and ARBs, angiotensin receptor blocker, and beta blocker we can give. The beta blocker is propranolol, and the angiotensin receptor blocker is candesartan. We can give to prevent the migraine. But these two types of medication is contraindicated in the asthma because they constrict the respiratory bronchiole. They are contraindicated in the asthma. If the patient is depressive patient and they also have the history of depression, we can give amitriptyline 10 to 75 mg per day. but this is antidepressant medicine that we can use in the prevention of migraine. We can also use azotyphine or histamine blocker. They are sedative histamine blocker. We can also give azotyphine 0.5 to 2 mg per day, but side effect is weight gain. Not all, sometimes. The azotyphine brand name is Musigar. That is available in the market by the name of Musigar, that we can be used for the prevention of the migraine. Syrup, Musigar or medicine tablet is also available. The flunarizine also used for the prevention of migraine. Flunarizine.